by saying welcome, everyone, to the virtual portion of the 2024 Perinatal Mental Health Conference hosted by Healthy Mothers, Healthy Babies, the Montana Coalition. As Anna mentioned, this has been an event that's been unfolding for the last couple months, and we've definitely tried to do something a little bit different than in years past this year. And so we're always open to any suggestions and feedback. And of course, at the end of all of this, there will be an evaluation offered. One of the biggest things that we tried to do this year is really think about how we could bridge that gap between in-person and virtual. Many of you know, we've hosted this is the 7th annual conference, and most of them have been completely in the virtual space. So last year, we did 2.5 days of completely virtual trainings and used this Whova platform as well as the Zoom platform to be able to bring us all together. Over the years, I feel like this community has really built a very good habit of lighting up that chat box and being really communicative and engaged with presenters and with one another. I really encourage you to, open up that Whova platform, get your questions in there, make connections with one another. This is a huge piece of the puzzle for improving perinatal mental health care in the state of Montana, and also for taking care of ourselves as we continue to do this very important and sacred work. I think one of the things that I want to start off with is we started with a perinatal mental health 101 recording that was done in September by Dr. Samantha Greenberg. She had an excellent 2-session presentation that's available on the Whova platform. It's also posted for free on our website. So if you've got employees, coworkers, whoever, folks that aren't registered for the conference, that's something that's also accessible. She's an exceptional family practice provider out of Kalispell, and so she really brings that context of practicing in Montana with families who are in that perinatal space. So I encourage you all to access those. A wonderful launching point into the world of perinatal mental health, and also just kind of nice to brush up on, if this is not something that you're consistently accessing but have been to past trainings. As Anna mentioned, last week we gathered in person in Helena. I want to give a huge thank you to the folks who were able to make it there and made time to be there for those 2 days. I feel like the energy in that room was incredibly high, and we had some really lovely sessions that you all are able to that everyone is able to access in the virtual recording spaces, also posted on Whova. I believe all of Monday is up, and all of Tuesday the 15th is up, and recordings for Tuesday the 16th are forthcoming. I will say that we had some glitches with some of the recordings for Tuesday sessions, and despite heroic efforts, there may be some pieces of that are not quite straight recordings, but we are doing our best to deal with those technical difficulties. We've got an awesome tech provider who is assisting us with all of that. So a little bit of patience on some of those Tuesday sessions, and know that those things are being worked on. And yeah, we appreciate the grace. I think that one of the things that I would also just like to start a little bit with is, one of the things about the Perinatal Mental Health Conference is that we're coming here across certifications, across training, across education backgrounds, geographies, types of settings that you're practicing in, really focus in on advancing care for moms, babies, and families in those very early stages of a child's life. And it's incredibly important. And I hope that this is something that, helps to build out your network and connections and continues to enrich your practice and your care of families throughout the year. So with that, I'm going to ask that we all migrate over. If you're in the chat box, I'm going to ask that you migrate over to the second session on your agenda. I'm doing this right now. So the title of our first presentation today is Preventing Alcohol-Related Concerns for the Pregnant Person Dyad.
This meeting is being recorded.
Cool. I clicked the wrong button. Sorry, everyone. So I'm a little off kilter. I am delighted to actually bring in a session that's focused solely on alcohol. As many of you know, alcohol is the most common substance used here in Montana as well as elsewhere. And I often feel like while we know and understand some of the risks that are present for folks using alcohol in unhealthy manners during the perinatal period and outside of that, we don't give a lot of intentional time to talking about those risks and really have a broad shared assumption that everyone understands and also understands how to intervene or what best care might look like. And I'm just so, as I was looking back on previous agendas, we've not had a specific session on this, and I'm just so excited that we were able to cultivate these speakers and have Dr. Klee and also Carolyn coming in to present this piece. So without further ado, I'd like to invite them to the stage. Both of these fabulous presenters, and I'll pull back the curtain a little bit. We had a late switcheroo in presenters for this session. And I just want to start out by saying thank you so much for being willing to jump in and come and share your wisdom with us about how we best care for families struggling with struggling with alcohol use in that perinatal space. So with that, I will turn it over to you all. We'll be here in the chat box to support you. So please just ask for what you need and let the audience know how you'd like to receive questions.
Thank you, Stephanie. Thank you, Anna, and thank you everybody for being here. I'm going to kick us off and then I'll hand over to my esteemed colleague, Carolyn Swenson, for the middle portion of our time together. And then I'll have a couple of comments at the end and then hopefully some time to answer questions. I can't see the Whova chat. And so I think if there's, Stephanie, anything that's like urgent, pressing, urgent clarification needed, please do jump in. For other questions that, maybe will spark some conversation, hopefully we can leave those until the end and have a little more time to talk all together. And so with that, I will get going. Neither Carolyn nor I have any financial relationships to disclose. Our goals today are, and thank you for being willing to talk about alcohol. Honestly, I think sometimes the universe brings the opportunities we need just in time. And so we're delighted to join you because really this is a topic that is near and dear to my heart and clinically incredibly relevant for many of us, all of us, I'll say, who are working with particularly younger people, people in that perinatal period, families with young children, for reasons that we'll describe a little bit later. That's a particularly vulnerable time. So we'll talk a little bit about exploring alcohol and health in people who could become pregnant, not only people who are already pregnant. Just a reminder about what used to be called FAS, but now really kind of a larger and more encompassing term of FASDs, fetal alcohol spectrum disorders, and how that information sharing and counseling can be used not in a threatening or punitive way, but in a supportive, hopefully feels more of a supportive manner. And then talk a little bit about SBIRT, really, give hopefully folks walk away from today with feeling like they've got a few more tools and ideas for how they would like to have these conversations with the people in our care. And then I'll talk a little bit about actual medication options, because I think even if you, a person attending this talk today, are not a prescriber of medications, particularly if you are, but if you are not a prescriber of medications, having some knowledge about the options for medication can often really open a door and be a game changer for patients who have never been offered or never even known that there could be a medication that could help reduce cravings for alcohol, for example. Okay, really, this one question, right? If there's one question we want to store in our toolbox, it's this, single question about pregnancy intendedness. And so this is sometimes called the ACOG one key question, which is, are you hoping to become pregnant in the next year, right? This would be the most appropriate question for somebody who's not already pregnant, But people who've recently been pregnant or even are pregnant, helping people think through not just pregnancy intendedness, but pregnancy spacing. Almost 40% of pregnancies in the US are unintended, and that's for all comers. That statistic for people who have substance misuse or substance use disorders approaches 60, 70, 80% of unintended pregnancies in some samples. And so, really asking people, do you hope to become pregnant in the next year, can open that window to several health behavior discussions about if you were to become pregnant. And that's something that you do desire in the next year. Is there anything that you want to work on as far as your health today? Are there things that many of us have the experience of becoming pregnant and then thinking, wow, I need to make this change, or I want to work on this health habit or unhealthy habit potentially. But wow, being able to give people space to think about that ahead of time can really change the conversation for a lot of our families. A word about kind of terminology that I'm going to be using. May use the term female, woman, mother. I may use some of those gendered terminology. Really, what I want to emphasize is that biology, meaning sex that a person was born, and biologic sex actually matters quite a bit, as well as gender expression, right? And so both matter when we're talking about vulnerability for alcohol, alcohol use, alcohol related health concerns, and development of alcohol use disorder. People who are biologically female actually experience these health related complications both earlier in their alcohol consuming life course and at lower levels of drinking compared to biologically male people. And that includes, so what that really means in plain language is people who are biologically female do not need to drink as much for as long in order to have these significant health problems that we associate with alcohol use. And that includes not just hepatitis, but many different types of liver disease, the most severe form of which is cirrhosis or liver failure. Alcohol consumption at all is related to heart disease, brain disease, breast cancer. People who are biologically female are also more likely to experience blackouts, which doesn't mean losing consciousness. An alcohol-induced blackout means kind of this separation of consciousness from behavior such that people can appear to be alert, interacting, talking, driving a car, right, having conversations or doing activities that person does not recall at all when they have less alcohol in their body. That is particularly scary. Alcohol is the original, what people used to call date rape drug, but it is the most pervasive substance involved in sexual assault, and particularly for people who are vulnerable to those blackout experiences. Just to kind of bring this to our attention that despite this information, the folks who are behind marketing and whose job it is to sell products that contain alcohol, and this was like so classic. I love that, Carolyn, that you included this Virginia Slims, ad that really kicked off a movement of advertisers understanding the power of the female demographic as far as a target audience for not only advertising tobacco or nicotine, but really advertising alcohol, right? If you look at some of these examples, these are not typically the type of advertising campaigns or presentation that an advertising company would create to appeal to a stereotypically male consumer, right? And just to remind us, as we're talking with, maybe thinking about this information, as we're looking around our world, as we're talking with the families that we help support and take care of, in the background, whether we're conscious or not, is really this cultural phenomena of what Carolyn and I think of as like the mommy drinking culture. So this messaging around alcohol is the way that you will cope with the stressors and the difficulties. And alcohol is the way that you will bond with other parents of young children. You see this in kind of funny memes, right? Like the old-fashioned images of the mom with her head on the table that says, kids, this is why your mommy whines. And it's talking about a glass of wine, not WHINE. Or, many of you can probably picture these memes or these things in your mind right now. Onesies that are very cute that say mommy's drinking buddy, matching wine glasses and sippy cups, right? There's kind of like a humorous component of it, but underneath all of that really is for a lot of parents, this messaging about we see how hard this phase of life is, and alcohol is a way that is socially acceptable for you to cope. Um, and once you kind of have our eyes open to that messaging, you will see it everywhere. When we're talking with folks about their alcohol consumption, this just as a reminder, especially in the universe of supersized serving sizes, this is what one drink is. And so when I talk with my patients, really sometimes I'll try to drill down to like, how do you know how much you're drinking? Is it like based on a bottle size that you purchase and like that bottle lasts 2 days? Or is it based on you actually pour it into some container that we know how big that container is? Are you drinking, by a discrete single serving? Such as a single beer bottle, like how do we know how much a person is drinking? Very often, by the nature of alcohol, folks may have an idea of how much they started out intending to drink, but may have a hard time quantifying actually after a drinking episode exactly how much was consumed. And so even sometimes having that conversation and drawing attention to, oh, could we be curious about like how much actually are we drinking? How much are you drinking? How would we find that out? I have found to be a pretty helpful starting point for folks who are starting to be curious about their relationship with alcohol. Lower risk drinking limits, right? So this is lower, again, going back to what we talked about as far as like the difference in biologic sex and how alcohol affects female physiology compared to male physiology. Over the age of 65, everybody behaves more like female physiology, is the takeaway with respect to like alcohol risks when you're looking at this chart. The lower limits for female people is due to that phenomena that people will have more health effects at a lower amount of alcohol consumption earlier in their alcohol consuming life course. Helping people really think through that this is not like punitive. This isn't saying women are, can't be trusted with drinking or can't handle their alcohol, right? It's really about the health effects and how we see those show up for female people. Helping people also remember that there used to be kind of this red wine myth that like, we have to drink some red wine for our heart health. We called that the health halo. That health halo has been broken. Red wine does not have anything special that you cannot obtain in eating, a variety of color fruits and vegetables. And so we don't need to drink any alcohol, actually. Sometimes I'll ask patients, I'm like, how much alcohol do people need to drink to be healthy? And the answer really is zero. Like all of us could live the rest of the days of our lives without consuming alcohol and have health benefits, right? There would be no health deficit or no health harm from completely avoiding alcohol. And some people make that choice even without having a history of problematic alcohol use or alcohol use disorder, based solely on that health kind of benefit of no alcohol consumption. And really we'll talk about this again, but the data has been presented in so many different ways. Some of you may have read Emily Oster's book, who looked at the data around the recommendation to not drink alcohol in pregnancy. And it really sparked a lot of pushback saying that, this data that we have demonstrating harm from alcohol is weak data. And so people should be allowed to drink and not, it was a really confusing way of presenting some data, but really the way that I interpret, and most of the folks working in the space and who are concerned about the health of pregnant people and their families, look at the data, is that based on a general population, right, there's no health benefit for any of us of consuming alcohol. And there's also not an amount of alcohol that I can tell somebody with certainty is zero risk for their pregnancy, right? Just like I can't tell anybody who's not pregnant, this amount of alcohol is zero risk. There's actually no zero risk. There's less risk and then greater risk. And so for that reason, really, the guidance that I encourage us to provide is that there's no lower risk amount of alcohol use during pregnancy. And so our recommendation should be none. What really comes out of that is the complexity around our relationship, both as individuals and collectively as a society, with alcohol itself. And so, when I've pushed some of my colleagues to say, like, hey, have you ever counseled a patient that they should not drink any alcohol during pregnancy? That brings up some discomfort. And I think for any of us who work with families, you could think through that scenario of what would it feel like to say to people, you should not drink at all. Um, it's it's more than just that individual person, right? I just want to keep in mind, like, this is something that's like so deeply rooted in our culture and society around the way that we interact with alcohol, that I think that that's part also of the discomfort. From a substance use perspective, alcohol, frankly, for us as healthcare providers, potentially, is likely to be the substance that we ourselves have the most experience with when we're talking with our patients, right? So sometimes when I'm talking with colleagues and patients using substances, there's something that feels more separated and less risky talking about patients with their methamphetamine use, for example, right? It's more uncommon for healthcare providers to have their own personal or family experience of methamphetamine use. But alcohol is not that. Alcohol is something that becomes much more personal for many of us having these conversations with our patients. So a couple of key points around perinatal substance use. Oh, and I've got to see, Carolyn, am I on my last slide? I can't see the
I think you
numbers.
have a couple more.
Couple more. Okay, well,
FASD,
just
yeah.
cut me off when it's our time to switch because I
That's
can't
okay.
see the numbers. Um, Pregnancy is often a highly motivating time for change, right? Many people become interested in their health, are often interacting with more health care than they may during a non-pregnant episode of their life. They may be more open to resources and recommendations for improving their health and the health of their family. Pregnancy is also, thankfully, not permanent. And so people who become pregnant are pregnant for a time. And sometimes, like all humans, are able to make some changes in a health behavior for a short period based on a key motivating factor. And then once that motivating factor is done or gone, thankfully, right, the pregnancy is resolved, that postpartum period for many people is a highly vulnerable time for returning to substance use, including alcohol. We also find that people who drink alcohol during pregnancy are more likely to also have associated tobacco or cannabis use. And so something about that, the folks who are able to stop alcohol use completely maybe are also people who were able to stop other substances. It seems like folks who are really struggling potentially with completely stopping a substance during a pregnancy episode may also have other substances that they would benefit from support and counseling around. Alcohol and other substances that we know, right, several that we know of, do cross the placenta and are passed through breast milk. And really, these physical, mental health, and social factors in the pregnant person are also important. It's not just the alcohol itself, right? And so there's the idea of like, what is the exposure during a pregnancy of the alcohol? Like, what does the alcohol itself do? But there may also be life circumstances around which a person is using alcohol as a coping strategy that also could impact their health and the health of their pregnancy, right? And so sometimes I've gotten a lot of mileage out of asking people, what does alcohol do for you? What does it help you with? Like, what is its function or role in your life? And for many people, that helps folks start talking about anxiety, depression, insomnia, um, stress, right? Whatever it is that's kind of um, makes the alcohol use have a function and a purpose. And for some people, people will tell me it's fun, it's social, it's my right, it's not illegal. And so it helps you kind of know what type of conversation I might be having with a person, and how they view, kind of alcohol's role in their life, especially during a pregnancy. And then just to kind of keep in mind again, so, the ACOG recommendation is that we screen every person in pregnancy for substance use. Screening does not mean a biologic test. So this is not a urine drug test. This is not testing any umbilical cords or baby's meconium. This is asking people, every person during a pregnancy episode, using a set of validated questions or a paper and pencil or electronic screening tool, questions about their relationship with substances of misuse, right? And so when you read about screening recommendations, or if we talk later about kind of, screening, brief intervention, what we're talking about is the use of a validated tool, not a toxicology test. There is definitely implicit bias built into screening protocols anyway, even when applied universally. But some of the most difficult and painful data to review is how those biases and discrimination, especially around race and ethnicity, are compounded when we add toxicology testing to the mix. And so when we're talking about screening, just as a reminder, that means asking people questions or a self-report of a validated tool, not testing someone's urine, blood, hair, etc. We think this is our best guess of prevalence of alcohol use during pregnancy. When you think about this percent, right? So in more recent years, 18 to 2020, this was pre-COVID. We have some really strong data that alcohol consumption, especially among women, skyrocketed during COVID. And so I would be curious to see in another few years what this data reflects as far as alcohol use during pregnancy. But we think somewhere in the ballpark of about 13 to 14% of pregnant adults in the US report alcohol use. And about 5% of those folks, a little more, reported binge drinking. So for a female person, right, 4 or more drinks in an occasion in the past 30 days. And those with no usual healthcare provider, mental health provider, and those who reported more, so people who are kind of on the fringes, right? People who are kind of like not in routine care, and people who also reported mental distress, which we're using in this data as kind of a marker for depression, anxiety, maybe a perinatal mental health or mood disorder, were more likely to consume alcohol. And so just as a reminder that alcohol can be the point of discussion that really helps us figure out what other needs does this person have, and can be for a lot of people, using any substance during a pregnancy can be a barrier to getting medical care because of stigma, discrimination, shame, etc. Okay. And then fetal alcohol spectrum disorders. Old terminology was FAS, fetal alcohol syndrome, recognizing that actually very few of people affected by prenatal alcohol exposure have some of these classic features of facial changes, right? Physical manifestations. Probably more commonly and less easily detected are folks who have alcohol-related neurodevelopmental disorder, or folks who physically do not meet criteria for fetal alcohol syndrome, but do have some of the behavioral and cognitive challenges that sometimes don't show up right away, right? That isn't apparent in infancy or early toddlerhood, but really more as kiddos get into the school age, that some of these alcohol-related neurodevelopmental differences may become apparent. There definitely are folks who have alcohol-related, what are called alcohol-related birth defects, which is not just brain or facial bone development, but can also affect development of the heart, kidneys, bones, skeletal system, and our hearing system. And so really the key message for the general public, right, is what I alluded to before, is that there really is a lot of misinformation out there about alcohol, but really the encouraged amount of alcohol during pregnancy would be none. And if that feels scary or impossible, let's talk about it. Because sometimes when we're trying to make a big behavior change, right, going from drinking alcohol to not drinking alcohol, sometimes we don't know how difficult that might be until we try. And so asking our patients, does that feel like something that you will be able to do? Does that feel hard, scary to think about? And opening that conversation. And with that, I will hand it to Carolyn.
Great. And Kaylin, I'll just tell you when to advance the slides, if that's okay, rather than going through the switching. And I guess this is a great time to pause and see if you have any questions or comments that you'd like us to address briefly at this point in the presentation. While you're thinking about that, I'll just thank Dr. Klee for that excellent introduction to alcohol. And hearing nothing so far, I'll go ahead, right? But jump in if there's anything.
Go ahead, Carolyn. Yeah.
Yep. Okay. So the next section, I'm Carolyn, really happy to be with you also, really grateful for the opportunity. And I'm going to cover something called SBIRT, Screening, Brief Intervention, and Referral to Treatment, which is simply a framework for addressing a variety of health risks. We identify a concern, and then we have a conversation and figure out with a person what are the next steps that make sense for them in terms of a change in their health behaviors, other aspects of their life to support their health, and of course their pregnancy if they're pregnant or wanting to become pregnant. So we call it SBIRT. And I'll walk through what it is and what the background is to support SBIRT. If you're interested in learning more, if it's new to you, there's a lot of resources out there now, and I can definitely help connect people to training opportunities and resources. And I'll introduce a couple of those as we go along. So next slide. So SBIRT, again, stands for Screening, Brief Intervention, and Referral to Treatment. And as was already mentioned, when we're talking about screening in the context of SBIRT, we're really talking about just asking validated questions to identify a health risk. Alcohol or other substance use specifically is often associated with the SBIRT model, but it can be used to identify things like possible depression or anxiety. Validated, meaning that the questions we're asking were tested, researched, and shown to work in the population that we're screening. A brief intervention is really just a short conversation supported by the key principles of motivational interviewing, where we provide feedback to the individual that we're meeting with and focus on enhancing their motivation to change. The referral to treatment step is often not needed depending on the setting where you might be working with individuals who are pregnant or could become pregnant. It really means further assessment to identify, is there a diagnosis of alcohol use disorder or another substance use disorder? And what would that look like to help the person access treatment services and support for not only the substance use, but other issues in their life. And so we'll talk about that at the end of the presentation. Next slide. And then the next slide. So we're not going to go into great detail on screening questionnaires, but I did want to just highlight some that are most commonly used for alcohol screening with our patients, and they can be used not only in healthcare settings, but other types of settings where you might want to bring up the topic of alcohol. All of these options are in the public domain. There's no cost to use them. They've been really well tested with multiple populations literally across the world. Although I have to say that alcohol concentration varies by country, but these examples of questions are really the way we usually start off this process of bringing up the issue of alcohol and starting a conversation. So there's, in the United States, we often ask 1 or 2 brief screening questions of adults to identify, do they drink alcohol? If so, what is their usual pattern of drinking? For further screening, the most commonly used screening tool is the alcohol use identification test, known as the audit, which can help identify whether a person's alcohol consumption would be considered low risk, moderate risk, or high risk, and possibly even meeting the criteria for alcohol use disorder. In the perinatal setting, one of the most commonly used tools now that many of you may already use or be familiar with is the 5 Ps plus. It screens for any substance use, including tobacco, and takes a gradual approach to introducing the topic amongst in a person's family background, their partner, their personal use, and peers' use. And sometimes in perinatal settings, when the 5 Ps is used, there's the option offered to patients of a no answer option. If they just simply do not feel comfortable at that moment disclosing substance use, it is appropriate to honor that wish to not answer, and then consider how to bring up the issue of substance use, including alcohol, at another time in your work with the individual. And finally, if you're working with adolescents, the screening tool known as the CRAFT, which is an acronym that stands for the key words in the screening questions, and there are 6 screening questions in the CRAFT. The CRAFT stands for car, relax, alone, friends, family, forget, and trouble. This is a very well-tested screening tool for adolescent screening, and it covers all categories of substances. And so if you work with adolescents who could become pregnant or are pregnant, this would be a great screening tool to check out. Next. So after you've screened, you can go back 1. Yeah, great, thank you. I'm going to talk next about kind of the heart and soul of SBIRT, which is this conversation that we call the brief intervention. And it really is just a conversation using motivational interviewing principles and with a focus on meeting someone wherever they're at and looking at what next steps make sense for you and how can we increase your motivation to consider a change. Now the next slide, thank you. So I'm going to mention a little more about motivational interviewing. For some of you, this may be something you're extremely expert at, have a lot of experience with. Others may be newer to it. But I just want to highlight, what is it about motivational interviewing that makes our conversations both more comfortable for individuals that we're working with, but also more effective. Motivational interviewing is now well researched and tested with adolescents and adults to address a number of health-related issues or other life issues, actually. And so I'll just highlight what we mean by some of these key principles and how they help make motivational interviewing work. So it's based in the foundation of motivational interviewing really is compassion, concern, genuine concern for the well-being of the individual as well as their pregnancy, their whole family. And so although none of us would want to intentionally use shame or blame or judgment to try to convince someone to change a health behavior, it can be very helpful to be reminded that just to be self-aware of, are we potentially coming across in any way using unhelpful ways of introducing a topic or carrying out a conversation. And another reminder about compassion is that when we show this genuine compassion, especially to someone who's experiencing a lot of challenges in their life, it can actually help cultivate self-compassion in that person, because some people have really lost that self-regard and they don't feel good about themselves. So by showing compassion, we can cultivate that self-compassion. Another key principle is autonomy. When we really say very openly and clearly to a person that it is their decision to change or not change their alcohol use or another health behavior, it very interestingly can actually decrease a person's reluctance to change when they know it truly is their decision. Accurate empathy. So what we mean by this is really that we want to strive to understand how the person views the issue. We won't necessarily always agree with how they view an issue. For example, that alcohol consumption during pregnancy is not likely to cause any problems, but we still want to show that we're understanding how they see the situation. That's the accurate part of the empathy. And again, that actually can decrease a person's reluctance to consider making a change when they feel truly understood. Normalizing and exploring ambivalence. So ambivalence, I'm going to guess, is something that we have all experienced, and we all do experience when we're considering making a change in our life. So basically, it just means we both want to change and we don't want to change. And sometimes people feel very uncomfortable with their ambivalence. So if we can normalize that this is just part of being human, and the way to work through it is to help a person talk about it, to explore the benefits of change and the downsides of change. As Kaylin already said, just ask someone about their relationship to alcohol. What are the positive things and what are the not so positive things about alcohol for you? Affirming values, goals, intentions, and efforts. So we can almost always tie an issue that we're discussing, such as alcohol, with what really matters most to a person in their life. So I encourage whatever setting you work in to just find out what's the most important thing to you right now. What things matter most to you? What are your goals for yourself or for your family? Also, when people are struggling, to acknowledge their efforts, their intentions, the fact that they want things to be different. And when we express very openly to someone that we believe change is possible, it can actually increase a person's confidence about being successful and their actual success. The partnership part is really important, that we want to let the individual know that we want to work with them to figure out the next steps. And we can even say very clearly that we know that they have expertise on their life that no one else has. So they will have some insight into what's going to be most helpful and supportive to help them change their alcohol use. And then finally, a key thing in motivational interviewing is to try to focus more on the possibility of change rather than all the barriers and challenges around change, especially earlier in the conversation, while we're trying to help a person become more ready to take steps to change. So we want to really listen for any explicit or kind of hidden indications that a person wants to make a change, or they have reasons that change might be a good idea in terms of their alcohol use and other parts of their health and life. So next slide. Another thing about these conversations, and I would say that this is especially important in a perinatal setting, is to think about the fact that trauma is very often in the picture when a person is struggling with alcohol or other substance use. And especially if they've tried to change and it really having a hard time changing. Many people who find out they're pregnant do either stop drinking or drastically decrease their consumption of alcohol. But often people who've experienced trauma may struggle more with making that change. And so again, depending on the setting where you work with individuals, it may not be your role to go deeply into trauma, but to just be aware that trauma is often in the picture. And so when we're talking about trauma, of course, that could be interpersonal trauma, it could be historical trauma, multi-generational trauma, things like racism and the experience of colonialism that some populations have experienced can often be in the background. So some key aspects of trying to be as trauma informed and create a calm, very comforting environment and comfortable environment for the conversation can be really helpful. So being aware of the tone of our voice, our energy level, that being comfortable with pauses and silence can be helpful. And if appropriate, and if a person is willing or wants to talk about how they see the connections between trauma they might have experienced and their alcohol use, that's definitely appropriate. A focus on competence and internal capacity for change. Often we want to give a lot of information or try to offer techniques to people to make a change, but honestly, again, often people will know best what's going to work for them. So really trying to build that confidence that change is possible and that everyone has strengths. Sometimes we have to help a person sort of identify what are their strengths, what would work for them. And then finally, being willing to really focus on even very small steps to change. Often if a person takes small steps successfully, they become much more open to larger changes. And harm reduction would be an example of that. So a person might not see completely stopping alcohol use as a possibility, but we can definitely talk about what would harm reduction look like, and we will cover that a little later. Next slide. So another thing about being both trauma-informed and truly person-centered is to think about the language that we use. And so these on this slide are just a few examples of what would be considered person-first language, which tends to carry less stigma and bias when we're discussing alcohol and drug use. So you can see some examples listed here, and over there on the right, reasons that these alternate terms, like saying a person with an alcohol or drug use disorder rather than an alcoholic or an addict or a junkie or a drunk, is first of all person first language. It avoids blame and moralistic language, and it's more accurate. And for all of these examples here, that's one thing we're really striving for, is using accurate medical terminology. Just one other example in the interest of time, thinking about referring to a recurrence of symptoms or use of alcohol or other substances rather than relapse. And when we think about how we talk about other health conditions, we don't use the word relapse when it's diabetes and blood sugars have gotten higher, or other conditions that a person might be experiencing. So just a few examples to think about how we talk, and that language can carry a lot of meaning in terms of how we refer to things. Next slide. So for the last part of this kind of introduction to SBIRT, I'm just going to walk through what a conversation might look like. There's 4 steps that I usually present, and these are iterative steps. You might go back and forth, but generally there's just kind of a structure that can help the conversation be more effective. So step 1 would be, we simply raise the subject. Let's say you've completed some screening questions with the individual, or you've somehow learned that alcohol is in the picture that would be worth discussing. You can start off by asking permission to have the conversation. And also this is an opportunity to reassure the person that you ask all the patients or all the people you work with in your work about alcohol and drug use in order to provide good care. So you ask permission, and in most cases, people say, okay, I guess we can talk about this. If they did not want to discuss it, we would try as much as possible to honor their wishes. Next slide. So the second step we call providing feedback. And depending on the setting that you work in, the status of the person, are they pregnant? Are they wanting to become pregnant? Is it a postpartum setting? Is it someone not receiving perinatal care, but who wants to avoid pregnancy? There's different types of feedback that of course will be more or less appropriate. But in general, here are some key things to think about when we talk about feedback. First is to review their screening results or whatever they've told us about their alcohol use, just to confirm it, to learn a little bit more. This would be the opportunity to say, tell me, what are the benefits of drinking for you? What are the things that are positive? And what are some of the not so good things or the downsides? Normative feedback can be a really powerful type of feedback. And what we mean by that is that Earlier in the presentation, we talked about how alcohol consumption is so normalized in our population. It's considered just sort of a usual, ordinary part of life. And for many people, the amount of alcohol they drink just seems like what is normal because the people around them often engage in the same level of drinking. So normative feedback means letting a person know that actually there are these lower risk limits, but also that most people in the general population, if we look across the whole country, are not drinking above those lower risk limits or not very often drinking above those lower risk limits. It's also a chance when it's a perinatal setting to point out that most people who are pregnant stop drinking. They try to not have any alcohol while they're pregnant. And so it can be completely normal and ordinary to not have alcohol as a major part of your life or as something you would consume during pregnancy. Feedback can also send a clear message that there's no safe amount or time of alcohol or other substance use in pregnancy. Sometimes just asking someone what they know about how alcohol could affect the pregnancy can open the door to spark some curiosity and give a little feedback about what we know can happen and reasons to avoid alcohol. If a person is going to be breastfeeding, lactation concerns might be something to explore, especially in a postpartum setting, exploring contraception, and also just advising that people are thinking about avoiding alcohol and other substances even before they become pregnant. So whatever information we give, it's really important that we ask the person, what do you think about this information? How do you think it applies to your situation and your health? So we continue in having a true conversation. Next slide. So there's several things we can do in motivational interviewing and in this conversation to do what we call enhancing someone's motivation. One of the most common approaches is simply to use a 0 to 10 scale to ask a person how important it is to them to make a change, where 0 is not at all important and 10 is very important. In my experience, very often people are able to choose a number, and whatever number they choose, it can give us something to work with to do what we call enhancing motivation. So whatever number a person chooses on that 0 to 10 scale, so let's say they say a 3, not very important, but there is a little bit of importance, we would want to respond by saying, so what made you choose 3 and not a lower number? And what that can do in the motivational interviewing context is to spark some change talk, someone telling us there's a few reasons or that a little bit of motivation for making this change in my life, even if I'm not totally ready to change yet. So that's one technique. And on the next slide, we can also ask a person how confident they feel about their ability to make a change if they decide it's a good idea. Again, a 0 to 10 scale, ask them to choose a number, and again, respond by asking why that number and what could help them feel more confident. This technique can be especially helpful for a person who's tried to change and not been able to change. Confidence is a really major barrier for some people, and it really helps to bring it out into the open so we can explore with them what supports would help you be successful in making this change. And on the next slide, a few more examples of open-ended questions that can prompt further discussion about the issue we're discussing, for example, alcohol. Just kind of prompting again a person to think about change and anticipate, if I make this change, how would my life be better? How would I do this if I decide that it's a good idea to stop drinking now that I'm pregnant? How could changing my relationship to alcohol improve my life and my future taking care of this baby? So just curiosity questions to try to truly understand a person's perspective and prompt often some increasing motivation to change. And finally, the last step is what we call negotiating next steps. Again, very much meeting the person where they're at. This is another opportunity to affirm that it's their decision to change, starting off with their ideas, what steps make sense to them, and as much as possible, trying to come up with a concrete goal. That could be harm reduction, that could be stopping their alcohol consumption entirely, it could be getting further support. But to also, in the third step here, to really discuss concrete next steps and to not shy away from exploring what's going to be difficult, what's going to be challenging. How could you handle the challenges from your expertise on your own life? What would help you make this change? When we talk about who can support you, this is one opportunity to consider if there's a partner in the picture, how could that person potentially even change their alcohol use to support the person who's pregnant, for example? And we can affirm that a person is choosing a change, even if it's difficult, to improve their health and the health of their baby. Depending, again, the setting you work in, arranging next steps might be involving other members of a care team. And I always encourage that we thank someone for their willingness to discuss alcohol, because it is a sensitive topic. It's a difficult topic for some people to talk about, and just thanking them shows appreciation for their willingness to have this conversation. This is one example of a clinical support tool. It's developed by a program in Colorado, but people can access this as a mobile tool, but also request copies from the program in Colorado called SBIRT in Colorado. But what's pictured on the screen is an SBIRT pocket card for women. There's also one for adolescents as well, but just kind of walks you through how to have a conversation, what key information you might give as feedback. So with that, I'll turn it back over to Kaylin.
Perfect. Thank you so much. I didn't introduce myself very well, I realized, but I am mostly on the IRT end. So I am an addiction medicine specialist. And so I mostly am seeing folks who have had a positive screen and are referred for treatment. And people who have alcohol use disorders, substance use disorders, really deserve kind of our work as a healthcare team to identify who are those resources, right? Like when we're doing SBIRT in any setting, there are going to be people who end up needing more than the brief intervention, right? A smaller number, right? Many people will benefit from just having that conversation, and maybe a series of conversations over time, and benefit significantly from motivational interviewing. And then there will be a smaller percentage of those folks who really do end up part of what comes out of those discussions might be, in order to increase my confidence, in order to increase my success of being able to achieve my goal with reducing or stopping substance use. Those folks deserve, addiction or specialized treatment. It can look like a component of a larger care plan. And so when we're thinking about treatment, sometimes people think like AA groups and detox, but there's this entire ecosystem around people who are successful in recovery that often includes support people who did not think that they were signing on to be part of somebody's recovery plan, but often become a significant component. I'm thinking specifically for me and my patients that I take care of in pregnancy, home visiting nurses, their doula, right? People within a faith community, right? So there could be people, including yourselves, who are engaged in the lives of and supporting a person or their family who your support, even if you are not an addiction treatment specialist, becomes part of a coordinated treatment plan. So harm reduction is a couple things. What harm reduction is not is condoning substance use or condoning alcohol misuse, right? It is not promoting people using substances in a way that's harmful to themselves or others. Harm reduction is recognizing that all of us every day engage in behaviors that have some irreducible minimum of risk, and we do things to mitigate that risk, right? A great example of a harm reduction strategy that has been wildly successful on a public health scale is seatbelts in cars. And so when people get in cars, they put a seatbelt on, they don't wait to be speeding out of control, hydroplaning across a freeway to put their seatbelt on. We put it on in the driveway, ideally before the car even starts moving, right? And that's a great example of how to think about harm reduction for people with substance use, right? There is an irreducible minimum of harm and risk involved in using substances, right? So there's never a zero risk. And people in active addiction also do not deserve to experience preventable complications such as infectious disease, soft tissue infections, overdose, right? There's ways that we can help reduce the risks, even while a person is still engaged in what is ultimately a risky behavior. For people who are in that perinatal space, one of the biggest components of harm reduction is actually just getting routine prenatal and postpartum care. So even if people make no changes with their substance use during a pregnancy and postpartum episode of their life, the risks that we typically associate with substance use during pregnancy, such as preterm delivery, small for gestational age babies, etc., those risks are reduced if people are encouraged and welcomed to receive routine prenatal care, even if they do not become sober. And then medications. So sometimes when I show this slide, people are like, holy cow, I had no idea. There are many medications. The medications on the left-hand side of the screen, naltrexone, acamprosate, and disulfiram, are FDA-approved medications for the treatment of alcohol use disorder. The medications on the right-hand side are considered off-label, but that doesn't make them wrong. Many of these medications can be used in combination. All of these medications, even with pretty limited data in pregnancy for some, particularly disulfiram and topiramate, we have really limited data about safety in pregnancy. All of these medications, either individually or in combination, would be less risk than continued alcohol exposure throughout a pregnancy. And so helping people think about medications not as not as introducing a new risk, but introducing a way that helps reduce the risk of an untreated condition. And we can think about that similarly for depression, anxiety, PTSD, bipolar disorder, ADHD, etc. Right? So when I talk with my patients, I say, I'm not recommending this medication for you compared to some neutral perfect state. I'm recommending this medication to you, recognizing the way that you are suffering in your current depression or anxiety or alcohol use, and how reducing that stressor might, increase your health and wellness overall. And then just a word about nicotine use. There is some pretty interesting data showing that like nicotine replacement therapy, which is probably the most commonly prescribed to people, like patches, gums, and lozenges, are like particularly ineffective for female people, which is really interesting. So if you have a female patient who's like, I've tried all the gum, lozenges, none of that stuff works for me, they are right. There's some pretty interesting data that those medications just have not been studied well in female people, but do not seem to have the same benefit compared to male research participants. Other medications that, again, could be more, should be considered in pregnancy based on the risk reduction of ongoing nicotine compared to ongoing nicotine use could be bupropion or varenicline, which people sometimes know by the brand Chantix. And then just a closing thought, right? So we talk a lot about, open door, no wrong door. We are doors in a way, right? And so helping kind of like, as Carolyn was talking about, that change talk and kind of that motivational interviewing, I think what's really worthwhile about that that experience with patients is also seeing and noticing over time how it changes ourselves, and to encourage us to let ourselves be changed, and to be able to be that open door that by gathering, more knowledge, more information, maybe in your role, you're like, I'm never going to be a treatment provider for addiction. That's fine, but you could be the door that somebody feels comfortable opening up to about their substance use, and knowing how to help facilitate that person in a compassionate patient-centered way is treatment. That is part of care. And so with that, I will say thank you. I will stop sharing. And then if there's any points of discussion, questions, we would love it. Thank you.
Awesome. Thank you, Dr. Klee and Carolyn, for those presentations. So helpful. We had one question in the chat from Ashley. How do you recommend approaching the common recommendation of drinking a dark beer to be able to improve lactation? I think all of us have heard this, but this is it's a great question because probably a lot of us hear it. And also it really gets to that heart of, this social cultural aspect of alcohol consumption. So yeah, I'll open the floor for you all to answer that.
Sure. Yeah, I would be so curious in Carolyn's response as well. My approach is typically, like, hey, I think that is more about how I consider drinking a dark beer to improve lactation under the bucket of like magical thinking in medicine, right? Where like I magically think that this thing will have this outcome, but there really is no good data demonstrating that kind of like that red wine and heart health myth. That has not been a scientifically tested claim. And so I would not support it from kind of a medical and scientific background. For folks who are like, well, what can I do, right? We have some lower risk ways to improve lactation. And frankly, most of it gets back to like caring for one's body, right? Like hydration, nutrition, sleep, rest, right? Some of those things. I think we can get a lot more mileage out of discussing with our patients, both for their lactation supply, but also for just kind of general wellness. I think if folks are like, nope, I think this is the thing that works for me. When folks have kind of like an outsized, and I see this show up with cannabis a lot too, when folks kind of have like this commitment to alcohol to make it work for them, or this commitment to cannabis to make it work for them, I think then we're like hinting around a bigger conversation of like, what is it that you wish that this could do for you? And if you are thinking of using this in like a medicinal way, then let's be good scientists again and evaluate it. Like, what are the pros? What are the cons? How will we know if this is working for you and if there's more benefit than side effect, right? The same questions I would be asking if I was prescribing a medication, for example. And really trying to help people kind of observe their commitment to a substance more objectively as a way to start teasing apart, like Carolyn was talking about, some of that normal ambivalence, right? So it's super normal to have kind of these dichotomous thoughts in our mind about like, I both like this and want this, but I also don't. And so how do I help people have that conversations, ideally more with themselves? And we can just kind of be the guide.
The only thing I would add to that, which I think is an excellent response, is just that I know for some people it's like family lore passed down through generations, and just even acknowledging that people who might be recommending this or have experienced this usually have the best of intentions. So it's not like being dismissive, which I don't think anyone would intentionally be, but to acknowledge that, yeah, there's a lot of things that people in your life who might be recommending things, and I'm glad you're bringing this up so we can talk about it, but kind of treading gently when there's like, all of my ancestors, my grandmother, my great grandmother, didn't it work fine and we're all fine, is to not come across as dismissive, which I don't think anyone would intentionally do. It's a great
Totally.
question.
And building that autonomy, right? So like I sometimes will kind of joke, but not joke with my patients. I'm like, just like people kind of lose their social norm to not touch your abdomen as soon as your belly is showing, like people, it would be weird if you were not pregnant and people came up to you and touched your belly. And somehow people in pregnancy feel like there's like this loss of filter. Same with recommendation and guidance. I think sometimes in pregnancy, in parenting, people so desperately want to be helpful that they feel compelled to share every little bit of advice and tips and tricks without, I think so all of us deserve, what I say to my patients, all of us deserve to develop our own filter for that input. And you get to decide what of these recommendations actually are helpful and fit for me, and what are like, thanks, great aunt Betty, but no thank you,
I love that. I think that that's an awesome way to end this, is thinking about how we build up that autonomy. That is helpful in every single aspect, whether we're talking about substance use, advocacy for yourself within that, patient client setting or any other setting, and, feeling like a competent and confident parent. There's really nothing that replaces that. So I love that. Thank you both so much. I'll remind everybody, you can access, if you have a question from this session, please go into that chat box in the session on Whova and post your questions. We ask all of our presenters to come back and filter to go through those and respond in the weeks after they give their presentation. So if there's something pinging there, please jump in, get that question on the board, and we'll work to get you all a response. So thank you both for this so much. We appreciate it, and look forward to having you back at some point.
Thank you.
Great.
Thank you.